Dear Professor Picano, dear friends, dear colleagues, and good afternoon, everyone. It's a great pleasure and honor to talk today with on this topic of aortic stenosis and the usefulness of stress echo. I have no declaration of interest to do for this presentation. And the first step when we are talking about stress echo is to define the modality we will choose, the modality we will use in our patient. And of course, one of the most popular tests, as underlined by Luc, even in patients with aortic stenosis, is the use of dobutamine, because the feasibility is sometimes higher than the exercise stress echo. It's very accurate to test both the ventricular function from the left side and the right side. It's a little bit, of course, less physiologic than exercise. The change in aortic severity may be subject to the protocol that you use, and we have little data on pulmonary pressure. But at least in patients with low flow, low gradient, and both preserved or reduced ejection fraction, this is a practical and very useful test. In terms of stress echo modality, there is also post-exercise stress test, where the patient first performed an exercise on a treadmill or on a bicycle, and then at the end, at the peak of exercise, we perform echo. This is also accurate to test both the ventricle and the left and the right ventricle, but it's relatively inaccurate for the peak pulmonary pressure. You miss the kinetics of the change of pulmonary pressure throughout the test. And this is quite the same for the mean pressure gradient, when we cannot assess the change in pressure gradient from rest to a peak exercise. And practically in asymptomatic patients with aortic stenosis, the most preferred test will be to perform both exercise and echocardiography in the same time on a dedicated tilted table to test the left and right ventricle, to test the valve and the mean pressure gradient, and also the pulmonary arterial pressure. Then when we have defined the modalities, we have to think about the parameters that you will use. During exercise stress echo, for instance, of course, we'll focus on the left ventricular and right ventricular geometry and function, both during the test and at peak exercise, but also sometimes during the recovery. We will assess the valvular severity and, of course, the pulmonary arterial pressure. The main goal of these parameters will be to give you information and to provide some data on the reason why some patients develop or not symptoms during the test. And the ultimate goal will be to assess the outcome and try to improve the risk stratification, and why not also to improve the timing of surgery of this patient. So this is what have been published and recommended by the ERCVI in terms of protocol that you can use from rest to exercise. This is the whole flow exercise stress echo. Of course, at rest, you should evaluate and have a comprehensive echocardiography, where we will evaluate approximately everything you can. And then throughout the test, you will focus on mean pressure gradient and mean pulmonary pressure. Of course, you will try to assess the LV function at peak exercise, at mid exercise, probably with also in patient when you have a mid exercise around 100 and 120 beat per minute. And at peak exercise, you will focus on pulmonary pressure, on the gradient, and some recent data also suggest that the right ventricular function at peak exercise may be useful. Similar parameters may be also assessed during the recovery with important information too. Of course, you have to remember that it's strictly contraindicated in symptomatic patients. This kind of protocol and exercise stress echo and stress test in general is completely contraindicated when the patient has symptoms. This is now the classical protocol that you can use if you want to perform dobutamine stress echo. Of course, yes, there is a mistake here. This is not exercise, of course, but dobutamine with kind of protocol from 5 to 20 microgram per kilogram by minute. And you may also start at 2.5 in patients with low flow, low gradient, with depressed left ventricular function, and particularly in sick patients. This is a low dose test for the low flow, low gradient patient, but in a classical patient without too much comorbidities and to not so sick, you can reach 40 gamma. Of course, you will focus on LV function, and the wall motion score assessment will be crucial in this kind of patient. You may also quantify the aortic valve area and the mean pressure gradient. And here, the goal, one of the goals of the test will be to try to differentiate between pseudo-severe aortic stenosis and through severe aortic stenosis, because you know that in the guidelines, the management of these patients is completely different. So now if we look at the place of stress echocardiography in the most recent 2017 guidelines, you can see that dobutamine in this algorithm is still present in patients when the assessment of the aortic valve area, when you are in front of a patient with probably a severe aortic stenosis, after the assessment of the aortic valve area, after the assessment of the flow status, low flow versus normal flow. When you have a low flow, there is a crucial role for dobutamine when there is a depressed ejection fraction to assess the flow reserve. That means at which point the patient is able to have a recruitment in terms of function and improve and increase the stroke volume during exercise, and to differentiate pseudo-severe to through severe aortic stenosis. This is what you have here. In patients with reduced ejection fraction, dobutamine stress echo remains central in the algorithm for the management of this patient in the 2017 guidelines for the assessment of flow reserve. And there is three main indications in this patient. Of course, if they are symptomatic, no stress echo, no exercise echo, only a dobutamine stress test. If the patient had severe low flow, low gradient AS with reduced ejection fraction and an evidence of flow reserve, and if you have exclude pseudo-severe AS, it's a class 1 indication. If you have a low flow, low gradient AS patient with normal ejection fraction, and if you have confirmation that this is a severe aortic stenosis, of course, calcium score by CT is probably the cornerstone of assessment for this patient, but dobutamine stress echo may also help you to differentiate pseudo-severe to through severe AS. But if you have the confirmation that this is a severe AS, this is now a class 2A indication for intervention. And finally, for those with classical low flow, low gradient, reduced ejection fraction, but without flow reserve, and we know that this patient had a dramatic prognosis, if you confirm again that it's a severe aortic stenosis, and this is always very difficult to assess and to use dobutamine in this context, because you cannot have the assessment at a higher flow during the dobutamine. But if you confirm, for instance, with CT that it's a severe aortic stenosis, again, it's a class 2A indication with a level of evidence C for intervention. And there is some change in the recommendation from 2012 to 2017. For instance, the exercise parameters were taken out and kick off in the new guidelines, more particularly the change in mean pressure gradient and the change in exercise, also in pulmonary pressure, which was taken out. Of course, all these previous recommendations from 2012 were only level of evidence C. That means that it was a consensus opinion of experts. And if you change the expert from the 2012 to 2017 guidelines, of course, the consensus should be different. But this does not necessarily mean that you do not have to perform stress echo according to the guidelines, because there is a place for the usefulness of exercise echo in the guidelines. There is a place for exercise testing, which is quite well underlined in the guidelines to unmask the objective occurrence of symptoms, more particularly in those who are completely asymptomatic. But there is also a place for exercise echocardiography, because they underline in the guidelines that this may help to detect and identify the cardiac origin of dyspnea. And there is also an interest in terms of prognosis impact. Practically, this is the two main studies on which the recommendation from 2012 were based. On the left, you have this paper from the group of Luc Pierre, who were the first in 2005 to show that the change in mean pressure gradient from rest to exercise improve the prognosis value of echocardiography to assess the patient. They found that if you perform stress echo, if you quantify mean pressure gradient both at rest, and if you look at the change from rest to exercise, those patients who increase their mean pressure gradient probably are at higher risk of cardiac event during the follow-up. This abnormal exercise response occurs in 38% of patients, and this accounts for 78% of all the events in this cohort. And then these results a few years ago, 3 years later, were confirmed by this bicentric study from data with data from France and from Canada, with a different cutoff. Here they use a cutoff value of 20 millimeter of mercury, an increase of 20 millimeter of mercury from rest to exercise. And they found such a survival curve, event-free survival curve, allowing to discriminate very well those patients with a higher risk of cardiac event. And the specificity of this paper was that the selected patients were truly asymptomatic. That means that they excluded all the patients with an exercise test which was positive. So in true asymptomatic patients, when you look at the mean pressure gradient and its change from rest to exercise, you can obtain this kind of discrimination regarding the outcome of the patient. Nevertheless, in 2017, this negative study was published, and this is probably why the guidelines also changed their conclusion. This is a nice study published from Dr. Goubler from Paris, where they studied 148 patients. They simply focused on those with a negative exercise test. That means perfectly those who are completely asymptomatic. Some of these patients were conservatively managed, and those with a positive exercise echo, according to change in pulmonary pressure, according to change in mean pressure gradient, were also follow-up. There was only 12 events in this group of patients, and only 15 patients had more than 20 millimeter of mercury increase during exercise, with a very short and reduced follow-up of 14 months. So the conclusion was, of course, negative. If you look at the event-free survival of these two groups, it's quite the same results. But of course, these negative results are mainly influenced by the very low sample size and the very low and short follow-up. But if we have 3 studies, we can do a meta-analysis, at least for 2 studies. But this is not a robust data that I show you here. This is not for a publication purpose. It was just for the fun that I do that a few days ago. You can try to use the 3 papers put together, and you obtain this kind of results here with a random effect, which is the gold standard for such meta-analysis. You reach a significant odds ratio regarding the impact on outcome of the change in mean pressure gradient. Of course, there is a marked and impressive rate of heterogeneity between the results, because you can see that between these 3 papers there is different results, but there is still a place for exercise echo, or at least there is still a place for new studies, new data, to try to confirm or infirm the role of this parameter. But if you go back to the paper from Paris, from Goubler, there is something very, very interesting in this paper, and we have to underline this and to discuss this if you want. They provide this plot here, where you have the exercise-induced increase in mean pressure gradient on the y-axis and the pressure gradient at rest on the x-axis. And you can see that the relationship between the change and the resting mean pressure gradient are not so very strong, but this was expected. You have to keep in mind that the predicted maximal heart rate reached by this patient was only 83%, which is not a maximal exercise test. But if you look at this patient who increase of more than 20 millimeter of mercury their gradient during exercise, this is difficult to believe that this patient may have a good prognosis, more particularly when they have already a severe aortic stenosis. And for instance, for this one with more than 60 millimeter of mercury at rest, this is probably very severe, yes, and we know that the prognosis of this patient is not so good. On the opposite, you have those with a physiologic change in mean pressure gradient between 5 and 20 millimeter of mercury. We are quite all agree that this is a physiologic change during exercise. There is no big trouble with this patient. Probably they are good prognosis. And even those who decrease their mean pressure gradient, but because they have a moderate aortic stenosis at rest with less than 40 millimeter of mercury at rest, even this patient may have a physiologic change in their mean pressure gradient during exercise. But where I have some doubt is about this patient with severe aortic stenosis at rest and a marked decrease or even no increase on mean pressure gradient during exercise. Those who decrease this, I cannot believe that this patient may have a good prognosis. Of course, if they are not able to improve the mean pressure gradient in the function is not able to improve during exercise, there is probably something wrong in terms of ventricular function, and probably that this patient may have a poor prognosis. And of course, if you mix together those with a physiologic change plus this one with a decrease in mean pressure during exercise, you cannot observe any signal in terms of change of outcome between those who increase clearly their prognosis and this other group here. So I quite sure that to confirm or not this kind of data, we need more study and more data to go forward and to move forward. Another thing that it's important to remember in patients with aortic stenosis is that there is a change in pulmonary pressure from rest to exercise. These data from the group of Luc Pierre again, and that we published when I was in Belgium, we have seen that through asymptomatic patients with severe aortic stenosis and preserved ejection fraction, we may have a development of exercise pulmonary pressure during exercise, and this is associated with cardiac event-free survival as compared to the one. This is a physiologic mechanism, and this is not so surprising. But what is much more worrying for us is that if you only look at cardiovascular deaths in this cohort of population of patients with CVIS, the 7 cardiovascular deaths occurred in a group of exercise pulmonary hypertension during exercise test versus 0%. This is small numbers. There is no p-value associated with this, but this is something that, again, we need to study a little bit more. Other point, which is underlined in the guidelines, is the place of exercise test, not exercise stress echo, but exercise test. And according to such studies, you can see that sometimes it's possible to differentiate through to false, into bracket, false asymptomatic patient with aortic stenosis using an exercise capacity test and with the measurement of the peak VO2. This was true in the whole cohort in this paper. It was a quite large cohort for those kind of patients. And it was the same result and it was worse, even worse, when you only focus on those without aortic valve replacement, so without indication for aortic valve replacement. You can see that if you have a low peak maximal exercise capacity, low peak VO2, the prognosis of this patient, and we are talking about survival here, the prognosis of this patient is quite very, very reduced as compared to the patient. This also has been confirmed by another almost quite pilot study published probably more recently by Levy. This is a small group of patients, but again, asymptomatic one. they did not find any relationship between the severity of AS and exercise capacity, which is also questioning. But they underline in this paper that cardiopulmonary exercise tests may be useful to reveal the underreported or underestimated symptoms and to predict the short-term occurrence of symptoms in truly asymptomatic patients. So there is also a place for exercise tests. Last but not least, during exercise, you can also perform BNP measurement. There is some data in patients with heart failure that suggest that if you take a blood sample at peak exercise or in the 5 minutes after the peak exercise in the beginning of the recovery, you may have a small but significant incremental prognosis value in terms of prediction of cardiac event in the follow-up. And it was quite the same in this patient with asymptomatic AS. This paper from two centers, the group of Luc and the group of Philippe Pibaro, combined their data, and they have shown this kind of results. On the left, this is the tertile of increased BNP, of peak BNP, sorry, and on the right, this is the change from rest to exercise, and you have this almost perfect discrimination in terms of outcome and event-free survival according to the three tertile of change in BNP. So if you want to perform exercise tests or even exercise stress echo, you can perform a blood sample at the peak exercise and probably increase a little bit again the risk stratification of this asymptomatic patient. So in conclusion, exercise stress echo may remain useful in patients with aortic stenosis. Dobutamine stress echo remains the key test in low flow, low gradient aortic stenosis, always to differentiate through to pseudo-severe severe AS. And of course, we need time, but it's time for a strong effort to build large-scale, collaborative, multicentric, probably international trial to provide more data in this context, because we just have small, patchy, and different data from different groups, and even putting together in the meta-analysis is not enough. We need new and contemporary data. Thank you very much.